I have the pleasure of introducing the founder of this meeting, as well as the Ortho Healing Center in Los Angeles, and really just a leader in this area and a pioneer in this area, also organizing all of us. So it gives me great pleasure to introduce Dr. Sampson, who is going to talk about innovative treatments options for knee osteoarthritis.
Thank you, Bill, for the nice introduction. And again, pleasure to be here. So today I'm going to have a little bit of a unique lecture and tell a bit of a personal story. But in general, I believe we really need to work together and collaborate with both doctors that are here and industry that are here. There's a lot of resistance and skepticism around the world that I've been encountering by lecturing and visiting symposiums. There's a demand that's going to require partnering with industry to fund some of these clinical trials and advance the field. So there's an overall theme. Everyone in this room, we're all pioneers. Each and every one of you doing this has a bit of a pioneering spirit. You're going against the grain, you're trying something new, there's opposition, adversaries out there, and we're all collectively taking the time to come here and further expand options to patients, and it's challenging. So I'm going to share my story briefly. I'm going to share some new knee osteoarthritis data, as well as some new promising technologies. This is a great point that really hammers in a revolutionary way to think about orthopedic medicine. We are primarily cellular beings. We're essentially a universe of cells. A recent literature review, I found a great paper I encourage you to read. The average adult human is made of 37 trillion cells. That's phenomenal. What's happening with our patients in orthopedic injuries? In general, I like to get the concept, there's a failed healing response. It's a failed cellular response. The body was built to self-repair and heal, but as we mature with time, it can't endure the stress and it gets stuck. There's this symphony or biologic chemistry occurring within our body that's trying to orchestrate repair, and it gets stuck. And we're trying to figure out why and what happens, but you can see from these slides, immediately following an injury, there's a symphony of white cell orchestration, followed by inflammation, angiogenesis, stem cell communication that goes haywire. So to lighten things briefly, my mother recently told me I was in the playpen for quite a long time, and it made me really want to get out and explore and discover. So it sent me on this journey around the world, and I would visit foreign countries like Papua New Guinea and wear grass skirts and get into the culture and do things that had never been experienced by some travelers before, which then inspired me to get into medicine. And my father was an osteopathic physician, and ironically and sadly, it was him battling illness from diabetes and heart disease, and him being a patient that motivated me to go into medicine and seeing its limitations. The founder of osteopathy, A.T. Still, was a Civil War surgeon. And he found more patients were dying from the standard of care and thought there must be some way to encourage natural healing. And he had these quotes which were profound and ahead of his time, that the body of man is God's drugstore and has every sort of drug necessary for health. And man should study and use these drugs compounded in his own body, which really rings home true what we're doing today. So in 2007, I was working with a group of orthopedic surgeons, and they had told me about a group of doctors in Spain. And ironically and coincidentally, all three of those doctors from Spain are here today: Mikel Alvarez-Sanchez, Ramon Cugat, and Dr. Anatua. And they were using these on MCL athletes, and so we were treating World Cup soccer players, and we were finding these athletes were getting safe and great results with accelerated return to play. And unfortunately, over time, my body wears down too, and I tore my MCL trying to surf in California, and I applied PRP and felt firsthand the process. This sent me on a journey to really try to document and understand what is this PRP and what are growth factors. There was no US publications on MSK PRP, and so I collected the research for my hospital for an IRB and ended up publishing that literature review. And there were no doctors injecting knee joints with blood. I was terrified the first time the concept of injecting blood into a knee. I had heard with hemophilia that's contraindicated. And so I found one doctor in Bologna, Italy via the internet, Dr. Filardo, who works with Dr. Kahn at the Rizzoli Institute, and together we formulated some basic protocols and published it in the AJPM&R. This led me to create this organization to bring doctors together, publish textbooks, advance the field, and here we are today. Biologics, it really represents a paradigm shift in the way we think. And this is very threatening to a lot of doctors. We represent a very small minority in the world right here in this group. At other conferences that I've attended around the world, there's a lot of great skepticism for great reason. And I welcome that, and I think that's going to push us, just like Jerry's talk this morning, that we need to really classify and categorize what we're doing in what tissues. But what we're doing is not new. This is historical. Every new advancement in medicine encourages the same type of skepticism, in fact, perhaps more in the past. I was at the AAOM meeting in New Orleans last month, and I was impressed by Dr. Lanny Johnson, who was one of the first US orthopedic surgeons to introduce arthroscopy in the 70s. He was shunned from meetings in medical societies. In fact, he had a slide where one society had banned him from meetings. 10 years later, they awarded him with a Lifetime Achievement Award. Secondly, I have a patient who's a pioneering ophthalmologist, and he's interviewing all the pioneers of LASIK, which revolutionized ocular medicine. Lucio Barato from Italy similarly was thought as a quack, shunned from medicine, and now everyone around the country is experiencing the benefits of LASIK. Our practice is in LA. It's the Ortho Healing Center. We treat chronic injuries as well as weekend warriors. We often treat athletes in acute injuries from Los Angeles Clippers, as well as a lot of the USA and Nike team track and field athletes. LA is an active community. For better or worse, our patients need motion. They're doing things perhaps they shouldn't. And you can see these seniors doing activities and keeping moving. And we know arthritis is an epidemic that really starts following trauma. Following a knee meniscus or an ACL, there's a biologic change in that knee that's pretty much going to guarantee arthritis at some point or another. So we're looking on ways of intervening early. This is a great video that really speaks to treat the patient, not the image. We had the largest storm in 50 years in Malibu, and this is one of my patients in his mid-50s doing what's called shooting the pier. And I don't encourage any of you to do this on your own unless you want PRP or stem cell therapies. But look at his knee. It's terrible from an MRI point of view. There's grade 4 cartilage loss, suprapatellar effusions. This is someone we're not guaranteeing we're going to regrow your knee, but he is too young in his mid-50s to get a total knee arthroplasty, because what's this guy going to do following his joint replacement? He's going to go back out and surf. So we've been able to keep him going every year or two, doing either hyaluronic acid injections, PRP, or bone marrow concentrate, and he's continuing to surf. So to echo the collaboration, Dr. Jose Fabiolana, who's here with us from Brazil today, was very generous in sharing some of his data, which was looking at what's the role with PRP of adding hyaluronic acid in the same procedure. Is there a synergistic effect or no effect? And so what we did was he used high molecular weight, non-cross-linked HA, which was made by Euflexa, but of note, there was zero financial funding. Much like we discussed earlier, the importance of the blood panel, patients had pre- and post-platelet counts as well as inflammatory panels to rule out underlying gout, et cetera. They received 3 ultrasound-guided injections at 2-week intervals. They had 5 cc's of leukocyte-rich, red blood cell poor, and platelet counts between 800,000 and 1.6 million. And this was actually activated with autologous thrombin. There were 3 randomized control groups, PRP, HA, and PRP plus HA. And you can see the demographics. They were primarily grade 1 through 3 Kellergan-Lawrence and had failed conservative treatments. They looked at Brittberg VAS scores as well as WOMAC scores. And there's a couple of telling slides here that show, number one, all 3 treatments were effective with improved statistically significant VAS scores. And these patients were followed up to 1-year follow-up. And you can see the blue line, which is the HA alone, and you can see more profound effects of PRP plus HA and PRP alone. But interestingly, the effects were similar with VAS scores when looking at PRP plus HA and PRP alone. But this second slide is very telling, and that what it showed was, again, all 3 groups had improvement of WOMAC physical activity scores, which really indicate pain from procedure, sit to stand, function, getting these people active again. When you added hyaluronic acid to the PRP at the same procedure, patients were more active and had better relief for the first 90 days. These were statistically significant, but then they equaled out at 12 months. And so you can tell your patients, there was a small study that showed adding hyaluronic acid to PRP had a synergistic effect for the first 90 days, which got people feeling better and back into their rehab, which we feel is important. But at 12 months, those results were the same. And so you have to determine the benefit of that, and more studies are going to be needed. And so again, that's what these summary slides here show. And again, there were no adverse effects. And this will be submitted for publication shortly, explaining also the methodology that PRP increases autologous hyaluronic acid, thus the concept of adding the two. When we look at knee pain, I really break it down simply into 3 domains. It's not just as we call dump and go in our practice. If you're just doing an intra-articular knee injection, draining the fluid and injecting, that's okay to do perhaps, but maybe we're missing part of the piece, especially in more challenging cases. So you've got the intra-articular environment inside the joint with the effusion and all the biologic debris and milieu. And then you've got subchondral bone, which is critical, and we've spoken about, and you're going to hear today from thought leaders, including Dr. Hernagau and Dr. Sanchez, about techniques to address this marrow edema lesion that you're seeing that actually correlates more with pain than cartilage. And then lastly, the emergence of superficial structures that are now getting more awareness. We had Dr. John Liftoff gave a fantastic pre-workshop yesterday doing what's called neural prolo, which are dextrose injections to cutaneous sensory nerves, including these medial saphenous nerves, that also need to be addressed when dealing with pain. So we're evaluating some new technology that uses cryoneurolysis of these sensory nerves. Perhaps from a single treatment, we can start getting earlier results. And so this is technology that does a peripheral nerve conduction block that creates some temporary axon degeneration followed by regeneration. And so you do it either in an ambulatory surgery center or in an office-based setting and follow local anesthetic. Liquid nitrogen is administered at -88°C. This is well tolerated, and patients can get some immediate relief, which can allow them to get more active. It's important that they're investing in clinical trials, and there are 2 registered trials that you can look at, clinicaltrials.gov. And you can see multi-center controlled trials here for knee osteoarthritis, as well as to be administered 1 week before total knee arthroplasty to get these patients faster recoveries, decreased hospitalization, and complications. So next I wanted to talk about a homeopathic injectable. For all of us, we can agree there are very few injectables that we have at our disposal for these challenging cases. And so for years, we've been using Trameal with nice results. But again, to gain acceptance in the community, we really need to have randomized controlled trials. And so Trameal has a lot of benefits that have been shown in the laboratory, although clinically these studies have been lacking. They can downregulate IL-1, TNF-alpha, potentially create a good environment for cartilage. And so I wanted to share results of their Mozart study, which was a multi-center placebo-controlled trial. And they screened patients into 2 groups. You can see the groups there on the screen. And again, this was a placebo-controlled trial. Primary endpoints were WOMAC pain scores, as well as a 50-foot walk test. These are the inclusion criteria. I'm not going to go into great detail, but these patients had to fail conservative treatments. They had to have grade 2-3 Kellgren-Lawrence OA. You can read the rest there. More exclusions. They could not have had hyaluronic acid or HA recently. But you can see here clearly improved WOMAC scores following these injections. And these were statistically significant and, again, very safe improvements. Also improved 50-foot walk test from baseline, which began around 15 days following the first treatment. So to conclude their study, intra-articular Trameal and Zeal showed statistically significant improvements in pain relief and moderate pain from arthritis up to 99 days of their follow-up compared to a placebo. And this is appealing because when we're in the office and patients have pain, most of us have a consensus we don't want to put cortisone into arthritic joints. I was at a conference recently and someone said, if you don't like a patient, give them cortisone. Because you're almost tricking them. You're taking their pain away, and almost unquestionably, sooner or later, their pain's going to come back and come back quite angry. So this study, we have to acknowledge, does have some limitations. There was no long-term follow-up. The follow-up was really for 99 days. And also of importance, the injection was not delivered with any fluoroscopic or ultrasound guidance, which also may affect outcomes. With our patients in our practice, we want to keep them moving, and so we've been using various brace supports and orthoses to keep these patients moving. But again, these companies have a responsibility to come up with some objective data. And so Bauerfeind did a really neat study I want to share with you, which is published, and it was done at the University of Freiburg in Germany. And they looked at the impact of wearing a light brace orthosis on medial knee discomfort. And they looked at 31 patients. And they used Vicon technology, which is really cool, which is high technology used in major motion pictures like Paddington for computer animation, and they applied it for medicine science. They had infrared cameras, 3D motion analysis, and EMG. And you can see the videos here, how they analyzed biomechanics, and we're seeing more and more of our patients and elite athletes doing these biomechanical gait labs. And so what they found primarily was an improvement in knee adduction, as well as knee adduction torque, which can be very important in offloading that medial joint. And they found that 2/3 of their patients reported significantly immediate reduced pain, which we also see in our clinic, and 90% reported their knee felt more stable. And these are generally good requirements post-injection, provided that patients are active. I feel like patients need to get moving, and the knee had no blood flow initially designed, and so it was designed for activity, and so any way we can get our patients moving will be important. Lastly, I wanted to discuss a collaborative effort. We've been fortunate to work with orthopedic surgeons as opposed to against for the better good of our patients and have more option. So we launched a ambulatory surgery center in Beverly Hills called STAR, and you can see us all here working together as a team providing more options for the patient. Now there's a change that I foresee where MSK ultrasound, as you can see in the top corner, is critical for visualized guidance in administering a biologic, but we can see very little as far as what's going on inside this highway of cytokines. And so while this is a great way to deliver our injection, I foresee advancements of needle-guided cameras. If you can play the next video for me. So here you can see where we work with an orthopedist, and we actually are using a pediatric arthroscope, which is minimally invasive and easy to perform alongside our orthopedist. And now we can visualize the cartilage. Most orthopedists have been doing this for years, but for me it was eye-opening and really stimulating new ideas. This was a patient we recently did a case on Crohn's disease, and so what we did was a diagnostic arthroscopy and a lavage, and then we injected bone marrow intraoperative at the same time. And so I foresee a growth where we're going to be able to improve technology of how not only we classify and what cells we put in, but how we deliver them will also be revolutionary. So lastly, to summarize, I really believe biologics is a breakthrough revolution in medicine, and there are inherent challenges, and we all have responsibilities. This is dangerous in the sense that it can be abused and take advantage of patients, and we all really need to get together each year and collaborate and have data, and we're really part of history here, and I think it's important that we work together and collaborate. There's more and more major institutions that are now recognizing regenerative medicine. This past year, there's been multiple organizations hosting workshops, and the US Army has expressed interest in being involved in symposiums as well. Lastly, everybody at TOBI is a pioneer. We're all doing critical work that I really believe is going to affect generations to come. Thank you very much.
You had mentioned that you use cryoablation. I wasn't sure whether you were talking about the cutaneous nerves or some other nerve.
Thank you. The question was regarding the reference to cryoablation. Yes, if a patient has superficial external joint pain, basically tenderness along their medial joint line that's reproduced. A lot of OA, as we know, is weight-bearing induced and with activity. But if these patients have medial discomfort to palpation, perhaps we're not addressing their full knee by just injecting their joint, in fact, suprapatellar laterally when their pain is medial. And so there are new treatments looking at targeting these superficial sensory nerve only for symptom relief.
Brian?
Just two comments, Steve. In your study that you did with the PRP and HA, you said that the pain relief went out to 12 months.
Correct.
At 6 months, the groups came together. So I think we could say that the PRP and HA worked really well as PRP by itself. Actually, PRP with HA was better up to 6 months, and then from 6 months to 12 months, they were about the same. I just wanted to point that out according to your slide.
Yeah, but also we're looking at statistical significance, and we found significance for 90 days. As far, okay. That's for the, you're referencing the VAST, that's correct. Okay. But for the WOMAC was for the first 90 days.
Okay, and then one last point. John Liftoff did a great job yesterday, and he has coined the term neural prolotherapy. And in the AOM, we've debated this. There is also neurotherapy and prolotherapy. And this group is a large group, international group. I'd like to try to get that nomenclature under better control, where we prefer the term perineural injection treatment or perineural superficial injections, PSI or PNT, as the more accurate term, and that neural prolotherapy is a confusing term for us to use.
Great. Let it be known, perineural therapy.
Okay, our last question is in the front.
Concerning, I'm seeing a friend of mine who's a doctor's mother next week, and she has mild to moderate osteoarthritis of the knee and a meniscus tear. So I was just going to do platelet-rich plasma on her under ultrasound guidance. What do you think about adding hyaluronic acid? Do you think that'll be a better way to go?
The question was, I assume more of an elderly patient is coming
Yes.
in with moderate knee OA, and would adding HA to PRP be an option? And that's something you have to decide and discuss with your patient. Some options would be doing HA alone first and seeing how they respond. Oftentimes we don't use PRP as a first-line option, but that's certainly based on our data. If they're looking for more long-term pain relief and superior results, PRP may be a benefit. But for me, it's also not only important the degree of arthritis, but their activity level. I'd much rather treat an active patient with advanced findings on an X-ray or MRI than someone with mild findings that's generally sedentary. But in our experience, adding HA to PRP has been very beneficial. Many patients just want their best possible treatment option and don't have the time to try HA, potentially fail, and then do PRP. And then others elect to start with HA.